Thank you. So thank you for the organizing committee for giving me the opportunity to talk to you today about Avivo. We're excited about the technology we're developing, which we believe is going to enable ABO incompatible transplant widely using both deceased and living donor organs. Of course, now I can't get this to work. There we go. So I'm going to give you a quick background snapshot on the company and some background in transplant, which all of you are aware of already. So I'll go through that quickly. Then I'll go over some proof of concept data that we've developed in blood and lungs, and then how we think this product we're developing will actually or could potentially be used. So as a company, just beware that what I'm saying may or may not come true in the future. So Avivo started off as a spin-out company out of the University of British Columbia in 2000 as Abiozymes Biomedical. We switched the name to Avivo this September. And we're developing an ex vivo platform that enables blood type incompatible transplantation. So we're able to actually convert the antigens of blood cells. We believe that this technology will increase the utilization of the existing donor organ pool, enable better matching, so looking at things like size and HLA, and improve the equity of donor organ allocation. The data that I'm going to present today was generated by our founders and published in Nature Microbiology and Science Translational Medicine. So as everyone in this room knows, transplant is a life-saving procedure, but unfortunately the demand for donor organs greatly outstrips the supply. Last year in the US, and the data I've got here is all US-centric, last year there was about 41,000 transplants, yet there's still 116,000 plus people on waiting lists. And that 100,000 plus people on waiting lists only represents a fraction of the number of people who could benefit from a transplant. There's hundreds of thousands of other patients who are on dialysis or waiting or undergoing heart failure who could benefit from a transplant. And even on the waiting list, there's over 17 people a day dying. Yet, with this massive unmet need, we found it surprising that this is data, again, from the US, that last year there were over 28,000 potentially viable organs that were not even retrieved from patients. The vast majority of these were represented by lungs, hearts, and livers. And in addition, there was another 8,200 organs that were retrieved from patients and ended up not being transplanted. Now, it's not a simple algorithm to say why or why not an organ was transplanted or not. It's pretty complicated. But one of the factors in that decision-making process is blood type. I'm going to get to why that's important in a moment. But if you use that as just looking at those numbers, about 15,000 of those 36,000 organs that weren't retrieved or transplanted were type A organs. So just as a very quick refresher, obviously, for transplant and transfusions, we need to match blood type or at least have compatible blood types. And blood type is defined by carbohydrate cell surface antigens, and these are decorated on your red blood cells as well as the endothelial and epithelial cells that make up our organs. And the difference between the H antigen, which defines blood type O, and the A and B antigens is the addition of one terminal sugar at the end of the carbohydrate chain. So it's just, I don't know if you can see here. Yeah, it's just this one extra sugar here is the difference between H here, you can see H, B, and A. So what our scientists, and in fact, it's Peter Raffeld, who's sitting in the audience up there, was able to do is he identified a set of enzymes, or a couple enzymes, that are able to selectively cleave off the terminal sugar off of the A antigen in a two-step process, converting it into the H antigen, defining O type. And it's this conversion step that we believe is going to enable us to be able to overcome the ABO incompatibility in organ transplantation. So what I'm going to go through is sort of the progression of some of the experiments that we did, so leading up to a demonstration of utility in a whole human lung. So Peter's group first started off looking at blood and converting of type A blood to type O. And what's shown here on the left-hand panel is a FACS analysis of A blood This was treated at 37 degrees physiological pH with our enzymes and was converted to O blood, and that compared almost identically with the control sample of O blood. So this was just in physiological conditions in packed red blood cells and whole blood. What we then wanted to know is what happens if you do this in the presence of a perfusion solution. So we did a similar experiment in the presence of PBS or perfusate solution, in this case steam, and the samples were exposed to our enzymes at increasing concentrations. And we can see at 1 microgram per ml concentration, we see about just under 100% conversion at 30 minutes and 37 degrees. So we know these enzymes are active in perfusion solution and are able to convert blood cells. Next question, can we convert tissue cells? We took a sample of A1 aortic tissue, and this was immersed in steam solution. Obviously no blood present this time, so just steam solution for 4 hours at 37 degrees. And we see a massive decrease in the amount of A antigen present, and it goes down over 90%. So now we know that our enzymes are active in a perfusion solution. We know they can convert tissue. So the next experiment was we were working with Marcelo Seipel at the University Health Network in Toronto, and we undertook to convert whole human lungs. So these are type A1 lungs that were inappropriate for transplantation for a variety of reasons. These lungs were separated into control and treatment arms, and prior to treatment, this is maybe difficult to see, but prior to treatment on the cell surface, you can see that there are A antigens present and no H antigens present. And following treatment, there's essentially no A antigens present any longer and only H antigens present. So when this lung tissue was liquefied and analyzed by FACS, we saw an over 97% reduction in the A antigen levels on the surface of the lung tissue. So we thought that was pretty encouraging. So the next experiment was we essentially repeated the perfusion experiment. In this case, we did 3-hour treatment with our 1 milligram per liter of our enzymes. And again, we had the control and treatment arms. And then the lungs were rinsed out with fresh perfusate to remove the enzymes and just leave the converted organ. And then challenged with O plasma containing anti-A and anti-B antibodies. And what we wanted to see is would those antibodies bind? And what's shown on the blue line here, this is the control arm, and we can see that the circulating antibodies are very quickly bound up by the tissue. And then the red is our treated arm, where over the 4-hour period of this experiment, essentially there's zero binding of the antibodies to the tissue. And then the antibody binding is going to be sort of the initial step of the antibody-mediated rejection of the organ. So we view this as pretty promising. So how exactly would you use a product like this? The way we're using it is this product would be an additive to a perfusion solution or a preservation solution. And what I've shown here is a donor an organ has been procured from that donor, either a living donor or a deceased donor, placed into a perfusion device. Our enzymes are added over a period of time, either the transportation time or a period of time in the hospital. The organ is converted. And then immediately prior to transplant, the organ is rinsed out with fresh perfusate. And in that rinse out, our enzymes are removed. And then the organ can be transplanted into a patient. And I've shown here an O or B patient. So we're designing these enzymes to be compatible with all perfusion solutions, all perfusion devices, and either at 37 degrees or at 4 degrees. And it could be cold static storage as well. And what I forgot to mention in the lung study, we converted that whole lung in an hour. So we saw a complete conversion in a 1-hour time frame. And what we're trying to do is do experiments now where at 4 degrees, we're increasing the concentration of our enzymes so we can get that conversion completed it within sort of the 1 hour time frame as well, with the goal of being able to use this technology in the essentially in keeping with the time course of the different surgeries from different organs. So we're hoping that this technology will be useful to enable more incompatible transplantations. So first, what does an incompatible transplantation look like today? Well, the patient is required to to undergo somewhere between 14 and 28 days of pre-treatment where they're desensitized. So they go through sequential plasmapheresis to knock down the levels of naturally occurring antibodies, A antibodies in our case. And they start to undergo the immunosuppression therapy. And then a donor organ is retrieved from a patient, from a donor, put into some sort of device, and then transplanted into the patient. And during the first 14 days of following transplantation, the patient who received the organ continues to undergo desensitization treatments as required, continues with their immunotherapy and their immunotherapy treatment. And then after 14 days, the body goes through this process, which isn't fully understood, of accommodating the organ. So essentially, the body just accepts the mismatched organ. And what we've observed, the long-term outcomes of ABO incompatible transplantations are essentially the same as compatible transplantations once you get past that first 14-day period. So with our technology, we believe we no longer have to have this 14 to 28-day pre-treatment of the patient, but rather an organ becomes available either from a living or deceased donor. It's placed into a perfusion device. At the same time, patients are identified. Patient will be brought to the hospital. If time allows, there could be an opportunity to do a round of desensitization, plasmapheresis. They would immediately be started on their immunosuppressive drugs, and then the transplant occurs. During the first 12 hours or so, we're expecting that the organ will remain completely to be an O organ. And then over the next 12 to 14 days, we're anticipating that organ is actually going to convert back into an A-type organ. So those antigens are going to re-express themselves. But we know with the experience with other ABO incompatible transplantations that the body will accept the mismatched organ. So we just need to, again, understand what is going to be required from a desensitization protocol during that process to allow that accommodation process to begin. And then following that 14-day period, we would expect that the patients would just go on to the regular immunosuppressive regime. So really the advantage here is it unlocks the capability to do ABO incompatible transplantation with deceased donor organs. This whole process is that Vivo's technology is involved is an ex vivo process. And we believe that, as we said before, this will unlock more deceased donor organs. But importantly, even for existing matches, it provides existing transplant, it provides the opportunity to have improved matching for other components like HLA. And we all know that if you get a better HLA match, better long-term graft survival. And then importantly, the last point that's on here, having more O donor organs available will greatly improve the equity of donor organ allocation. So we're developing this device through the FDA, developing this product through the FDA right now, and it's being developed as a device, and it's going through the full PMA pathway. We're in the process of applying for breakthrough device designation with the FDA. And we're in discussions with them on what our first clinical study will look like. And it's looking like it's going to be a progressive study from identical organs all the way through to full ABO incompatible transplant in living kidney donors. And here we want to demonstrate, obviously, safety and efficacy. And success here would be not seeing any AMR after 14 days in the full ABO situation, and then monitoring organ function and 6-month graft survival. We have a variety of ongoing preclinical studies with University of Cambridge. We're using ex vivo human discard kidney model that we're working with them. Unfortunately, I don't have data that I can share, but what I can say is that this is looking very promising. At 37 degrees, we're seeing essentially a repeat of the lung data. At 4 degrees, again, we're working on concentrations to show that we can do the conversion in an hour or so. And we're also working with them on some extended studies where we're trying to keep the organs alive in the perfusion device for up to 24 hours, so we can get an idea on some of the antigen regeneration kinetics. And then we're initiating some heart and lung studies with the University Health Network in Toronto. And in January, we're starting a preclinical safety study in swine with UBC, where we're doing an autograft study where we convert the organ, rinse it out, and then put it back into the same swine, just trying to get a read on the safety of an organ that's been converted and understand what danger there is from exposure to any residual amounts of enzyme that could be present. So our pipeline really is we're focused on kidney and lung is close behind. Heart and liver are early stages right now. We're also developing this product as a treatment to convert blood. And this is really in the research stage. With the organs, it's pretty straightforward to rinse out the enzymes. With blood, because they're a liquid organ, it's much more challenging. So we're designing a tagged enzyme system with an inline filter to be able to remove those enzymes once the conversion has happened, and have that be a process that is amenable to how blood is currently being processed in I lost my train of thought, in blood processing groups. Try to make it as easy as possible.
I was trying to give you the word.
Yeah. And then we're also working on enzymes to convert the B to O antigens. So where we see our product fitting, if you look at what the future of the market landscape for transplant, you've got things to increase the organ supply, better utilization of existing organs, decrease rejection, both hyperacute and acute, living donors and deceased donors. There's a variety of different products, from cold static storage to perfusion solutions to desensitization. We see that our technology really is compatible and actually probably complementary with most of these approaches. And it's a way to increase the utilization of an existing supply of organs. We're not required to bring in more organs for this to see some utility. Obviously, we're not really competitive or synergistic with xenotransplant, 3D printing, or any of those, because those would be designed specifically to overcome some of the problems our technology is addressing. But just as a summary, we're developing an ex vivo platform to enable ABO incompatible transplantation in both living and deceased donors. We believe this will increase utilization of all organs, provide better matching opportunities, and importantly, provide better equity in donor organ allocation. Demonstrated proof of concept in human lungs and packed red blood cells and whole blood. And we're targeting getting into the clinic in 2024 in a kidney study. But we really see the long-term utility of this more in deceased transplant with heart, liver, lung, and kidney. So with that, I'm happy to answer any questions, and thank you for your time. Yes.
I have to say this is very cool. So my question is, do you think this enzyme can may expose some antigen that was cryptic, was cryptic before and now become exposed? So this may increase the formation of non-HLA antibodies?
It certainly could. We don't know the answer to that yet. We're looking to see if we can do an analysis to see if we're either creating cryptic antigens or if we're, as you said, uncovering some cryptic antigens, but we don't have the answer. But of course, the probability, not the probability, the possibility is yes, but we don't have an answer yet.
Thank you. That was, oh, sorry. Am I next?
Yeah, you're next over there, and then we'll go.
Thank you.
I think I'm next over here.
Oh, sorry.
Hi, that's okay. Thank you. That was a great talk. It's really exciting. Obviously, ABO inequity is a huge problem. I'm curious. So you mentioned obviously the A glycans will eventually return,
Yeah.
or that's the proposed thing. And maybe you know that a little bit from the lung work that you've already been doing. But I'm wondering. So when we do regular ABO incompatible transplant, we look at the level of ABO antibodies. So do you think that's something that still needs to happen in this context? Because if the antigens are coming back and then you have say someone with a very high level of anti-A antibody as opposed to a low level, do you anticipate pheresis or other interventions will still be necessary at that stage to try to mitigate the risk for someone with a high level of antibody?
I think I understand the question, but let me.
Yeah, I guess because we do titers typically now,
Yeah.
right? To see if someone's eligible for ABO
Yeah.
incompatible transplant. So would that still be part of this protocol that you have to look at the level of anti-A antibody going into the transplant and potentially do something about that as like A glycans return?
So I think the answer is certainly initially yes. We would definitely do that just from a safety perspective. But right now they do A2 to O and B transplants in patients with low-ish antibody titers. So I think 132 levels, and A2 have A antigen levels that are around sort of 25% of what's in an
That's
A2,
right, but they don't
A1
come
patient.
back, right? Like I guess I'm thinking of your
Right.
timeline of return of the antigen at a high level.
Yeah. So I'm going to ask Peter,
Okay.
which is completely unfair, but he's here, so I'm going to ask him as a resource. On ABO incompatible transplantation today, I think the maximum level that they would do is about a 1 in 256, but I don't know the answer to that. Okay, sounds like a discussion over lunch. But yes, initially, yes, we would do plasmapheresis just from a safety perspective until we understand a little bit more on the kinetics of the antigen regeneration.
So it wouldn't be an exclusion to participating in a clinical trial.
I don't think so.
And I think there was a question in the back over there.
Hi, this is Laura Sly from UBC and BC Children's. Very elegant set of studies. It was very beautiful. Thank you very much. I noticed your first paper was published in Nature Microbiology, and I was wondering if these were microbial glycosidases that you're using.
Yeah, so these enzymes were identified from the human microbiome, and the observation was, and I'll probably screw this up, but Peter will correct you over lunch. The observation was that septic patients, their A-type septic patients, would have this syndrome called acquired B syndrome. So essentially, they're leaky gut, and their blood starts to turn to something that looks like B. So there's this observation that the microbiome has enzymes present that are able to convert the blood antigens. So Peter underwent a metagenomic study where he looked at hundreds of thousands of gut bacteria and screened through those and identified a series of bacterial leads that have these enzymes, and then screened those to identify the ones that we have. So
Yeah, that's fantastic. Thanks very much.
And then currently we're producing these in E. coli to scale them up.
So I have some questions in terms of your prioritization of your final product.
Yeah.
So your number one, I guess, product is a kidney transplant, which seems like it's a high bar, but you haven't, at least according to the timeline you showed. I mean, to me, it seems like changing the blood type of blood would be the sort of the easiest and the most sort of widely applicable question, because it doesn't regenerate. And then the second one, to me, in my mind, would be blood vessels that we use in transplantation all the time. We have to wait for, getting the appropriate, it's a bar to get the appropriate blood type. That probably doesn't also regenerate. So having a sort of a ABO compatible blood vessels for use in transplantation would be an easy market as well. So, and then the next one to me would be liver, as opposed to all these other ones, because it's the most immune tolerant. So why are those on the lowest end of your sort of advances, and kidney, which seems like it's a difficult, really rejecting kind of organ, is at the top?
Well, so I'll answer the question that I can answer. Is the reason we're not going after blood initially is really one of function. We don't have a good mechanism yet to remove the enzymes once it's been converted. So we don't want to have the enzymes floating around in the converted blood. We want to actually remove those. So that's part one. And then I guess on the why we're selecting kidneys first, because there's this massive data already out there around ABO incompatible transplantation in kidneys specifically. For us, it's a safe way to start to demonstrate utility of the enzymes.
But there are a lot of data on ABO incompatible liver transplantation as well. I mean, I think the Asian market, for example, with living donor only transplantation, has done decades of work on ABO incompatible liver transplantation.
We should definitely be looking at that then. Thank you.
I have one quick question if there's no others. I was confused a little bit by the clinical trial model that you're proposing, where you're starting off with a pheresis session. It seems to be not necessary. And whether, I mean, it's almost like it undermines the whole purpose of the drug to do the pheresis before you actually do the transplant. If the device is going to remove the A part of the antigen from the A molecule.
Again,
Or is that something that somebody imposed on you that you had to do?
So we haven't had that imposed yet. This is an ongoing discussion with the regulator. But our thinking, again, this is all predicated on you want to make this as safe as possible for the recipients.
I just worry that by setting the trial up like that, going forward, when this product is used, it's going to require people to do pheresis in a setting where I think if the treatment actually works as intended, you shouldn't need to do pheresis. It also makes it harder to follow the antibody titers afterwards, to Anne's question, because now you've reduced them, but of course there's going to be this rebound phenomenon that's going to actually make it very difficult for you to track the rebound in antibody titer after transplant, and what components of that is just reconstitution of antibody, and what may be related to the reemergence of the antigen in the tissue.
Okay. Well, all good stuff. Thank you.